Hello, everyone. My name is Ashley, and I'm so excited to present to you today with my co-author, Huang. Evan and Will also worked on this project with us, but they couldn't make it, so we will be presenting on their behalf as well. So today we'll be showing you how we developed a coronary heart disease model. So first, to get started with our motivation for developing this model, coronary heart disease is very common. It is actually the #1 leading cause of death worldwide. And in the United States, one person dies every 34 seconds from heart disease. And furthermore, 80% of these cases are preventable. However, currently, most people are diagnosed until after they are hospitalized, when their heart disease has gotten too far and has caused something drastic like a heart attack or cardiac arrest, when it could have been prevented in the past. Thus, we determined that an accurate and patient-accessible prediction model of heart disease using electronic health data is important and needed for the prevention of heart disease and to give people early treatment to prevent something drastic. So the population of the data set that we used was all patients on record at the UCI Medical Center. The data set was a random sample of 918 patients from the data that they had, and we used 75% of the data to create our model, and we saved the other 25% of the data to then test our model. From each person, values of 11 variables were collected. These variables were age, sex, type of chest pain with and without exercise, resting blood pressure, level of cholesterol that they had, blood sugar levels that they had, and their maximum heart rate. In the table, old peak and ST slope were also variables in the data set, which both correspond with something called ST, which is a medical measure that indicates the level of tissue damage in the heart. It was also, of course, recorded in the data set whether the patient was ultimately positive, meaning that the patient had heart disease, or negative for heart disease. We began our exploratory analysis by looking at the distribution of our response variable, heart rate, versus possible predictors from the data set. Some of them we noticed didn't have differences between the groups, such as resting blood pressure. However, others did have noticeable differences, such as the differences in means for age and maximum heart rate, looking at the first and last box plots. Others had different spreads, such as when we look at cholesterol levels. These factors shown here turned out to be significant predictors as we created our model, but there were other predictors to look at as well. We moved on to looking at some potential categorical predictors. Some of the interesting ones that we showed, that we looked at, showed differences in proportions between those with and without heart disease. Some of these variables were sex, fasting blood sugar levels, and exercise angina, which is chest pain while exercising.
Then we move on to our model construction. We basically fit a logistical linear regression model to our variable of interest, which included both categorical and quantitative variables. And then we moved on to model selection, which uses the AIC and SBIC method of the information criteria to ultimately decide on our final model, where we dropped four variables, which is resting ECG, resting blood pressure, maximum heart rate, and peak ECG readings. With our final model, we plotted a logit plot, which showed a fairly linear association between the predictor and the response variable. Then finally, so with that in mind, we can arrive at our final model, which has the predictor of age, sex, chest pain type, cholesterol, fasting, what was it? BS, exercise, GINA, and the SD slope. And when we performed a model, what was it? A model F test, we got p-value of 2.2 times 10 to the power of -16, which showed that our model is fairly significant compared to an intercept only model. We also performed a collinear plot, which shows that we show no significant collinearity between our variables. And overall, looking at the confusion matrix, we can see that our model performed fairly well, very well, both in terms of its both in terms of predicting negative cases and positive cases. We also, just to extend our analysis, we also tested our model against a more rigorous model. So we basically split our data set into two parts, one 75% in size and the other 25% in size. The big data set was used for training the model, and the small data set was used for testing the model. And then we use a lasso method to penalize the model and choose the most appropriate predictive variables, which also arrived at the same final model. In conclusion, we found that both sex types, age, sex, types of chest pain, cholesterol level, fasting blood sugar level, and presence of exercise-induced chest pain, and SD slope were all important factors in the prediction of coronary heart disease. We found that age is highly correlated with the presence of coronary heart disease because the buildup of fats along the artery walls and hardening of blood vessel over time increase the likelihood of heart disease. We've also found that males are more likely to develop heart disease than females. We suspect, using current literature, we suspect this is because men have worse coping mechanism to stress, which likely to induce heart disease in the long term. Additionally, we also found that chest pain is highly correlated with heart disease and is often used as an early indicator of heart problems. Yes, and this is our sources.
I would also like to add that given the accuracy of our model, an interactive web application of our model was created in order to make it widely accessible to the general population. The interactive application takes a patient's health indices that we mentioned before, the significant ones, as input, and outputs as the predicted probability of them having the heart disease. And we also gave them a 95% confidence interval of the probability of that patient getting coronary heart disease. And our interactive application can be found as a link in our paper that we submitted. We hope you enjoyed our presentation, and you can feel free to reach out with any other questions if you have any.